what we've done with CAR T cells in multiple myeloma is come a long way. We've had several meetings this year, starting with ASCO and then EHA and now EBMT, which is coming up, where we are finally getting data where we have longer follow-up. We have a lot more patients, and there's 3 big studies which I think we should be focusing on. One of them is with ide-cel or BB2121, and that study is called KarMMa. This was first presented at ASCO, then at EHA, and part of it will be presented at EBMT as well. This is probably one of the largest sort of experiences in the context of multiple myeloma in the very late stage relapse refractory patient population. And the data which has been presented is 128 patients. These are patients who've pretty much seen everything out there. So they've seen both immunomodulatory drugs, which includes lenalidomide and pomalidomide. They've seen both proteasome inhibitors, including bortezomib and carfilzomib, and have also been treated with a CD38-directed strategy, so either daratumumab or isatuximab. So traditionally, if you think about this patient population, it's an extremely difficult to treat patient population. And when we've looked at retrospective data in this patient population, the outcomes are quite poor after you've been exposed to all of these drugs and are refractory to the majority of these. And on an average, we see progression-free survivals of about 3, at most 3 months, with overall survivals of, less than 8 to 9 months. So really, I would say that this is an area of true unmet medical need. Now, with the KarMMa trial, this was exactly the patient population that KarMMa treated. This is ide-cel or BB2121 in the 128 patients. And once you get to the recommended dose, which is going to be 450 million cells, you see an overall response rate of close to 80+%, and patients who actually achieve a stringent complete response in this patient population had a median progression-free survival of 20 months. If you take all 128 patients across all dose levels, the response rates were in excess of 70%, with a median progression-free survival of a little over 10.5 months. So really quite robust data when you sort of compare it or put it in perspective of what these patients had previously received. I think the other really important thing to note about this trial was the fact that, this was almost a global effort. So a lot of the accruals happened in the United States, and then we were able to go transatlantic, and a lot of accruals happened across Europe as well. So sort of a designer-specific approach, if you will, which was able to be accomplished globally, is quite remarkable, and really important to underscore the fact that despite going from a phase 1 now to a phase 2 study, we really were able to recapitulate what we saw in the phase 1 trial. We did not see a lot of additional toxicity, which I think is really critical when it comes to CAR T cells. And, the 2 big toxicities that we worry about, like cytokine release syndrome or neurotoxicity, was very manageable. Neurotoxicity, if in fact, was hardly ever seen. CRS was seen in about the majority of patients, but most of the CRS was grade 3 and grade 4 and was easy to manage. So we are seeing high response rates with durable remission durations in a very refractory patient population with acceptable toxicity. And our hope is that this is going to get approved for the treatment of myeloma patients at large. Along the same lines, a couple of other CAR T cells were also presented at these meetings. One of them was a Cartitude trial, and the Cartitude trial uses the J&J CAR T cell product. And really, the difference between ide-cel and this J&J product is the fact that this CAR T cell is able to bind to two separate epitopes of BCMA. And by doing so, the thought is that it's a tighter binding and you're going to be able to see a deeper response. The good news is 100% of patients who actually got the active dose of the CAR T cells had a response, and the majority of these patients remain progression-free at a follow-up of about 9 months. I think the argument here is the follow-up is a little low, the numbers are smaller, but nonetheless, the data looks really very, very encouraging. And the toxicity, again, seems to be acceptable, and we need to look at the longer follow-up on the Cartitude trial. We had another trial, which is the Evolve trial, which was also presented. This is a different CAR T cell, also known as Orva-cel. And the difference here is really the differences between these different CAR T cell products in myeloma are subtle. And the big difference with Orva-cel is the starting material that we use. The starting material which goes into making the CAR T cells uses a combination of CD4 and CD8 T cells at a 1-to-1 proportion. So half CD4s, half CD8s, and then they're manipulated, and then they're made, then the CAR insert is put into this product. So whether or not these differences, the biepitopic binding or the CD4-CD8 ratio, or not doing any of this, is going to make a difference in the context of both efficacy, long-term outcome, and toxicity is something we still have to wait and watch for and have a longer follow-up with this. But nonetheless, what we're seeing with all of these products, especially with Orva-cel as well, we're seeing a response rate of 90% plus. Again, the follow-up here is a little bit shorter. This was in 60 plus patients. So again, what you're beginning to see is a robust number of patients where you're seeing deep responses, and the duration of response is something we are still trying to figure out. What we are also seeing is the toxicity profile of all of these products seems sort of comparable and seems to be acceptable. So all good news pieces for patients with multiple myeloma in the context of CAR T cells.